my topic today is on syndesmotic instability. Now, the inferior tibiofibular syndesmosis comprises of the anterior and posterior inferior tibiofibular ligaments, and the vascular supply to the syndesmosis is mainly from the perforating branch of the peroneal artery, which arises around 3 centimeters proximal to the joint, and a 24% contribution from the anterior tibial artery. Now, the movements of the inferior tibiofibular syndesmosis are extremely important for normal gait. When you have extreme plantar flexion, the fibula migrates anteriorly and correspondingly migrates slightly posteriorly when you dorsiflex the foot. Now, high fibular sprains happen when an external rotation stress is applied to the body with the foot planted onto the ground. This can happen in various contact sports, such as this, or it could happen in road traffic accidents. Now, the commonest type of isolated syndesmotic injury happens with an external rotation stress across the ankle articular surfaces. You can elicit tenderness in the region of the anterior inferior tibiofibular ligament. External rotation stress tests can be painful and can elicit instability in certain cases. And if you do the squeeze test, i.e. squeeze the tibia fibula together in the region of the mid-calf, you can elicit pain in the region of the syndesmosis. You may wish to do further investigations like standing x-rays, comparative x-rays with the opposite side, or even stress radiographs. MRI scans would reveal ligament injuries, and the CT scan, especially if you can get a weight-bearing CT, would show findings similar to the X-rays, but to a much better definition. Arthroscopy can be used in certain cases where there is subtle instability, especially in high elite athletes. The question is to diagnose whether it's a stable or an unstable injury. An isolated syndesmotic injury can be of grade 1, where there is tenderness but no obvious instability. This is best treated conservatively. In cases of grade 2 injury, where there is partial injury, normal radiographs, but a positive external rotation stress test or a positive squeeze test, the management of these is a bit controversial and depends on the demands of the patient. A complete syndesmotic injury, which is commonly seen in a high Weber C type of ankle fracture, generally needs stabilization with screws, tight ropes, or combinations. Now, in subtle or instabilities, you can use an external rotation stress test as demonstrated on the picture on the left, which will show an increase in the medial space between the medial malleolus and the talus and lateral talus shift. You can use the lateral gravity stress views where it's much more comfortable for the patient and it seems to be as accurate as the manual external rotation stress view. You can use a CT scan where you can define the difference between the anterior and posterior measurement at the level of the syndesmosis. And we recommend doing bilateral ankle CTs so that you can have a normal side to compare with. You can use syndesmotic impingement tests like arthroscopy to assess for the syndesmosis, where in such cases you will find a syndesmotic fringe, which is generally very inflamed in the region of the syndesmosis. Now, intraoperatively, you can test the syndesmotic stabilities by the traditional hook test or an external rotation stress test. In patients with a high fibular fracture, the dilemma comes whether to fix the fibula or just treat it as with syndesmotic screws. If the fibula fracture is within the middle third or lower third, we recommend fixing the fibular fracture as it will restore your length, alignment, and rotation and ensure that the fibula is restored to its normal alignment. If you do decide to do just a syndesmotic stabilization, then we recommend a slightly anterior approach at the level of the lateral malleolus. You will sometimes find that the AITFL is folded inside the syndesmosis and needs to be fished out. Beware that sometimes the superficial peroneal nerve will be right at the level of your incision. Testing the syndesmosis in this region shows frank instability as shown in this diagram with the hook test. Now, our recommendation for these injuries to stabilize them is to find that anterior ridge of the tibia, distal tibia, that is the anterior border in the region of the incisura. And we recommend passing a 2 millimeter K-wire at that level. This acts as a buttress, which we can use to stabilize the fibula against and ensure that the fibula is perfectly reduced in the syndesmosis. We then, if required, use a traction through a pointed reduction clamp to restore the fibular length, apply a perilock clamp to cause compression across the syndesmosis, and then ensure that the fibular length has been restored. So you could use 2 screws, or you could use them through a plate. We recommend them you use through a plate, as it's a much better biomechanical construct. As this can be seen in these 2 years radiographs of the same patient. Now, arthroscopically, you could assess the instability of the syndesmosis by anterior-posterior translation. You could then debride the syndesmosis to remove any synovial fringes in that region, and then recheck the syndesmosis once you've stabilized the syndesmosis. You could use 1 screw, 2 screws, small fragment, large fragment screws, 3 cortices, 4 cortices, but there's evidence to show that the screw size and the number of cortices do not matter as long as you can maintain the stability by any of those measures, depending on the patient factors as well as the accuracy of reduction. Tight ropes can be used to stabilize the inferior tibiofibular syndesmosis, and they are very effective in reducing them in most cases, but as ineffective in patients who have a high fibular fracture with significant shortening of the fibula, as they are unable to restore that fibular length. In those scenarios, we recommend screws. There are advantages of tight ropes that they don't need removal in most cases, but they can cause late failure, problems due to the fiber wire, or osteolysis. So whether or not to remove the syndesmotic screws, our default position is generally to retain them unless they cause problems, i.e. pain or prominence. But there are enough retrospective studies which show that functionally, the slight improvement in the movements as well as the functional outcomes after removing the syndesmotic screws. Thank you.